before that in such a situation, or in these situations, we very often need a multi-modular approach. And as you can see here, just if we look at the TVAR and FEVAR numbers, this is almost 30%. TVAR alone, that typically is extended to the celiac trunk, branch stenting, and in some specific indications, we also have to do complex false lumen interventions. So overall, in this 15-year period, we had 37% of patients needed secondary interventions. Now the question is, what are they? Here's an interesting example with a patient who presented with this aneurysm close to the valve that got immediate ascending repair. Shortly thereafter, she presented again with severe chest pain, and she needed a redo of the valve. And you see the dissection now as a new onset of dissection. Again, redo, valve, arch repair, and frozen elephant trunk. The problem was that the cardiac surgeon put the elephant trunk in the false lumen, and then we had to deal with it and try to connect the false lumen, which was successful here, coming from a true lumen, going underneath into the false lumen, fed and connected. So that was one of those procedures that were very important. But that patient came back later in about a year because she had chronic expansion. Despite that, we had extended down here to the more closer to the celiac trunk, and then she got the classical repair using the fenestrated stand graft and then got a FEVAR here. Very similar case, or very similar patient, had also false lumen expansion secondary to his FET procedure. And typically these patients, they have inflow and through and through flow in the false lumen. And here the big question was, Thilo, perhaps you might have put a candle plug in here, but we were shy of doing that because we saw these many inflows in. The other problem was that you had a large re-entry down here in the external iliac. So we decided really to try to close all those inflow and through flow collaterals, fill it up with rapid fill to make sure that all those feeding vessels are occluded, and secondarily place then an IVD 2 months later. And just the Friday case, patient who had still a visceral ischemia right after post-arch repair and the FET. And here you see this static stenosis here coming from the dissection. Could be an argument whether stabilize could have helped us here, but we decided just to really put a stent graft in there, and that resolved the problem. So in conclusion, about 1/3, if we look really long term after arch repair, of these patients will need some intervention, and TVAR and FEVAR are mostly at a later stage, not in the really early acute stage. TVAR alone, typically this is trying to extend the FET to the celiac trunk. This is early or midterm. Branch stenting is earlier or late, and these complex false lumen interventions typically are then done as late procedures. Thank you very much.